work in a different environment. First, I don't do 90 cases per day like John. We have mostly all we need. Remember, we are work in a setting, we have all well framed. One tips for you before you leave the room, if you want to go to mission trip, always make links with local doctor. Somebody have to follow those patients. This is, for me, the most important. Also, don't be afraid to put stitches. If you believe you have any doubt about the cornea or the wound is leaking, put one stitch. What is the problem? Nothing. You don't want to go back to OR and relapse your working day. And this is important. Now let me talk about my management. We, as you know, Honduras, Central America, 1 hour, 50 minutes from Miami. It means the wealthy people from there, they come to Miami to shopping on the weekend. The poor people work in large factories there. And this is the most, 69% of our population live below the poverty line. It means we have this contrast. But for me, I start my management of my post-op cataract at the end of the procedure. I am a follower of Jimmy Gills. You ever know about Jimmy? Jimmy loved to put antibiotic and steroid inside the eye. Also, I was trained by Doc Perry. Doc Perry said, if you want to harm the conjunctiva, put antibiotic and steroid in the conjunctiva, and I promise you will have a really scarred conjunctiva later. In that reason, I prefer to work in different situation. Also, we have some protocol. I am a man of protocol. I follow my protocol because it's easy for me. All my tech, all the people working around us, they know what they have to do with our post-op patient. And this is easy for me. I am the laziest doctor in the room because I don't do anything. Just I have people surround me that they do everything for me. See? And okay. My protocol starts before to finish the surgery. I am afraid to inject antibiotic in the vitreous body. I do retina, I do vitreous surgery, but I prefer to start my surgery with putting antibiotic intracellular. I go below the pupil and I inject Bigamox. I just take 0.1 cc from my bottle. Most of the time, Alcon gave us some samples and just inject that. And I know through the sonnulas, you will have a good concentration in the vitreous body. And also, if you read about where the endophthalmitis start, they start behind the posterior face of the lens and the anterior face of the posterior capsule. This is the area where most of and if you put the antibiotics there, you have a big load of antibiotic in the risk area if you want to be more success. Second, I use triamcinolone preservative-free. 2 reasons. First, I want to anti-inflammatory effect, but also it helped me if I have leakage through my side port, my main one. Remember, I work a little bit different from Glenn. 99% of my time I go through my side port. I use my side port to do my irrigation, my aspiration, and most of my surgery I do through the side port. And I don't use my main wound. I don't want to distort the anatomy of my sclera, and I go there. And that's the reason that I be sure that my wound, my side port is 2 millimeters. It's really big. But because I follow the Arabin technique, they use that technique. This is the reason that helped me. I put antibiotic and I use steroid at the end of the procedure. That is as a first step. Then I left my patient and my technician comes and they follow this protocol. It's a protocol. They put pilocarpine. Many people say, why do you put pilocarpine? I said, the patient want to have a better, they will have a pinhole effect the next day. This is good for their mind. Also, if you have a raise at the intraocular pressure, it's okay, pilocarpine help. It's just 4-6 hours, but it's going to help. Second, in all our patients, we put saline, hypertonic saline solution. We don't know the cornea look like that you see today, but why we don't can improve a little bit more? I put ointment, hypertonic saline solution. Also, they put antibiotic and steroid in ointment. Plus, for me, this is the key, always, before and at the end of my cases, I use Povidone, 5%, and it's fantastic. You don't need to use this fancy antibiotic. It's just to dilute your 10% because you available normally is 10. You dilute it to 5% and put some drop, and that's it. The other reason is we don't patch our patient. See, because my environment is so nice that I have shields and you don't have shield, and this is for you, John. You can go to the X-ray hospital and you can cut this plaque and you put in staples, and you can make your own shield if you don't have. But it's normally I have it. I don't have this problem, and I put a shield. I don't patch the eye. Then, because I want to start the drops 1 hour later, I am really aggressive because the level of education of our patient, you know, it's happened. It's not. This is real. We say to the patient, you have to put your eye in your eye. He put in the nose, in the ear, in the mouth, but he didn't put any drop in the eye. And also, at the end of the surgery, one of our tech give a sheet of paper with a lot of, with all the steps that he has to use. We work with the family and the patient, but most of the time the patient, they are so sleepy because during the surgery we use some benzodiazepine or something like that. We use painkiller as a routine. I use from India, the name is Combiflam. It's not marketing. It's a combination of ibuprofen and acetaminophen. It's really good. I give 4 pills to the patient. They take 1 after to finish the surgery. At the end of the day, they don't need to use the other 2. Sometimes they say, you have a headache or you have some problem, you can take it. But I use that because, and this is my protocol. I use steroid every 2 hours. I don't care the company, or because we are an NGO, we have access to buy supply from India. Also, we have a local company that they produce really good steroid with antibiotic. But we always try to use the lowest cost for us, because you remember we are an NGO, we are self-sustained. We have to be successful, but also we have to be really good in our economy. Okay, the patient, they left the clinic with right information. Then the next day they come back with us, and again, I don't do anything of this. Our technician come and they. This is the reason they are so aggressive. See, I explained this. This is our environment, and you can see it's not big. Maybe it's worse in Africa, but it's not like Latin America. You've been in the poor areas in Latin America. It's almost the same. Okay, see, this is one of our technique. When the patient comes with us, the first, like Glenn said, for me, it's really important, the visual acuity. I don't care what is the visual acuity of the patient, because, you know, to avoid these small hyphemas, because I work with some cornea doctor, and I noticed that if they want to, when they do the SEC, they left a bubble of air in the eye, and I say, why? Sometimes you have this small blood vessel bleeding in between of the wound construction. You say, I can leave a 10% of air, and I leave air. and I know I won't have high FEMA. This is the reason that sometimes I don't have a high FEMA. But my patient come and we check the visual acuity. It is not important what he sees, but I need to know if he improved. If the patient is on motion and it's 2200 and they have a 10% of bubble, he improved. He's happy. He can move by himself, herself. I don't care. Also, I check the pressure to all our patients, all 100%. We bought from China. I am a fan from China and India to buy equipment and eye care, and they use the eye care, and we use the short tonometer. If the pressure is high, that's 5%, 10%, whatever, I don't care. We check at the sleep lamp with the Goldman tonometer. It means that patient have 3 different evaluations with 3 different instruments. What is the pressure? And then we continue with the same treatment. If the patient has the pressure below 30, I don't do anything. If the pressure is 35 or higher, I do tap, I use Stimulol, twice a day for a week. In a week, this patient come with us. This is Stuart Sonheimer, he's a friend of mine. He worked last week with us. We check the visual acuity, but also we check with refraction and K. For me, it's important because sometimes I am obsessive compulsive with my surgeries. It means if I believe my surgery, it won't correct enough astigmatism, I put a stitch. Not for my wound construction. It's just thinking that my patient has to be free of glasses the most that I can provide. And I put a stitch. And this, for me, this is the reason that I check the K, the IOP, the sleep lamp examination. I dilated all my patients and check the fundus, the optic nerve. I use my indirect ophthalmoscope and check the periphery to try to see if we have some small tear, or I never seen the retina before. And if the patient needs laser, we schedule for laser. We have a small room to put laser. We put laser. Also, at this moment, I add NSAID, and I start drop my treatment. Remember, I start 1 drop every 2 hours the first week. The second week, this is the way that I use for a month. You notice all my patients, at least, we have to follow for a month. 4 times a day, 3 times a day, 2 times a day. But at this moment, I add diclofenac or whatever we have. And then if the cornea is still a little bit inflamed, sometimes it happens, the patient has the ointment, he still continues using the ointment. It's not, we retire as a treatment. Okay, a month. This is very important because refraction, if the patient say, doctor, I see well, I can read, I live without glasses. I stop antibiotic and steroid. I continue with the NSAID twice a day for another month, because it's amazing. If you remember when we were in our residency, the study said 90% of our post-op patients have some type of cystic macular edema, clinical or angiographic or whatever. And this combination of NSAID and antibiotic and steroid is good for that situation. And then we discharge the patient. If the patient needs to surgery in the other eye, I schedule for the other eye. Sometimes, because I am in a place that I don't move, it's easy for me to do that. But if you go to mission trip, you can do one eye one day, the second eye the other day. It's up to you. But I see my environment is completely different. I live there. I can follow my patient. Most of them we can go there to find them because they live in this area, but it's not far away from us. The biggest distance is 1 hour from our clinic. It's not a problem. Also, if the patient needs anything else, we move for a different scenario. For example, the patient has diabetic. We have a lot of diabetic patients there. We we do we start a week later the treatment with laser or Avastin or whatever they need. Special care for the pediatric cases, I do the same. I do anterior vitrectomy. I do also posterior capsulotomy. I put the implants in the back and they follow the same. And I agree with John. I use systemic steroid, and I be a little bit aggressive with my tropicamide and phenylephrine. I use twice a day for at least 15 days because I noticed that maybe the doctor here, she is an expert in uveitis, she can tell us, even the children, they have a huge inflammation. I am very concerned about that. That's it, you know, it's almost the same, but with small changes. I am very aggressive because the educational situation in my country. Do you have any question? See, this is the problem when you speak so bad English. Nobody understands you and nobody asks, but it's okay. Thank you so much.